one that is going to be in Abuja, Nigeria. It's July 10th and 11th, and we want the whole North American team to join. And this is actually bigger than the Best of ASPO because really we are looking at innovative technologies, therapies, and saying that we can't wait for years or decades before it trickles down to the African continent. How do we move this quickly as a continent? So that being said, at the end of this meeting, we'll share the flyers and we'll start discussing amongst ourselves on this. And we have a SIG that was created because of this, and we hope SIG meaning a special interest group, and we hope that you join the SIG to make to be able to help create access to the African continent. All right. That being said, I think we're already 5 minutes past the hour. And for this 15th session, we always normally have this North American series every first Tuesday of every month. And this month, of February, we have St. Jude's Children Research Hospital. They are the celebrants, if you will, of the hour. So they are gracious enough, and we are very privileged enough to have the St. Jude Children team members giving the talk for this hour. So we have the moderator who I'm going to be introducing, and then he will be moderating his team. So I'm privileged to introduce Dr. Nikhil Bhakhtar, who is an associate member in the Department of Global Pediatric Medicine at St. Jude's Children Research Hospital, and he's the director of the Disease Burden and Stimulation Unit within St. Jude Global. He leads the global initiative in childhood cancer epidemiology, health economics, hospital-based cancer registries, and adapted treatment guidelines, including the AREA initiative in collaboration with SEER. He is a pediatric hematology oncologist, and he has played a key role in shaping regional strategies for sub-Saharan African, and he advances data-driven approaches to guide policy implementation and prioritization of childhood cancer in low middle-income country setting. And this talk is really very important because we need to start prioritizing childhood cancers, which we kind of seem to I'm not saying the word ignore, but there's no as much movement, and I'm happy that this discussion is actually timely and we are having it. Please welcome Dr. Nikhil. Please take it from here. Thank you.
Thank you so much, Abiola, and thank you to AORTIC as well for giving this opportunity to speak. As you've noted, childhood cancer oftentimes gets missed in the broader cancer control space. And so this we feel is a very important opportunity to share with colleagues. And it's also great to see so many colleagues online as well. And hopefully, for those of you who want to leave some time for the questions at the end to hopefully have a little bit more discussion. I also would like to think about this a little bit differently. Many of the partnership models that I think we see out of North America follow kind of more of a bilateral partnership structure. I think what you'll see from what we do in the childhood cancer space is unique in that we've really modeled kind of a broader networked approach, really emphasizing not just north-south relationships, but more and fundamentally south-south relationships and maintaining kind of more cohort style approaches. So I'll give a little bit of a history of our program and our principles and operating mechanisms. Then I'm going to hand it over to Geeta Naidu, and Prof. Naidu is in Johannesburg leading our hub program, but also has been a long member of our St. Jude Global Alliance, who will talk more about work with fever neutropenia guidelines. Then I'll hand it over to Glenn Ma, who has worked with many different organizations within the continent to talk also a bit more about some of the national evaluations that we've been done with countries, as well as to talk about cancer registry work that has been done through the Global Alliance through St. Jude. And then finally, we'll leave Joyce Kambugu, who is our co-chair for our Regional Advisory Committee, to moderate the discussion and any questions that might come out. So to go ahead and jump in, to give folks a context of who St. Jude is. So we are a pediatric children's research hospital with a focus on oncology as well as hematology. And so obviously malignancies, but also sickle cell and other diseases as well are our main areas of focus. And our global work really has spanned now for 3 decades, such that in 2015, this was our footprint, really 24 programs in 17 countries. But St. Jude is also one of, if not the largest, health-related charity in the world. And through our calculations, we estimated that we were seeing maybe up to 2% of the global population and impacting only a minor number of children with cancer. And for that, led by our CEO, James Downing, we felt that that was insufficient. And you'll also note that in this map, this whole, showing where we were in 2020, 2015, that the entire region in sub-Saharan Africa was completely missing, and our partnerships really were limited to Morocco and then some in Egypt. So as a result, we were missing the area with the largest burden and by quantity of number of children that were needing access to care, as well as recognizing from an equity standpoint where the majority of children actually were probably in those in most need. And so when we started our program, really we identified several core values that we wanted to make sure that we followed, and this is really aligned with kind of our own perspective, having worked in the region for decades. And so first and foremost, we never really wanted to impose. We only worked where we were invited. So as we started working in the region, we only went where partners asked us that they wanted to work within our teams or with our teams. We spent a lot of time whenever we engage in new partnerships, never to duplicate. This is a core principle. And I think we see this all the time in global health and in global oncology, that two teams, both in the same program, sometimes in the same country, or certainly on the continent, are duplicating same projects. And we said that that's not necessary. There's more than enough work to do that we don't need to duplicate. Instead, continue to build on one another's success. We never dictate priorities. It's never St. Jude saying, let's do this. Rather, we engage in a process of co-design, really identifying what are the priorities of the partners on the ground that have invited us in, and then identifying where there's win-wins. Where are there things that I can offer as St. Jude, and where are there needs from the partner side, and where can we identify where those two might align? And then, of course, we don't think about this as really thinking about this from only St. Jude. If we're working with partners, we really want to think about who are all of their partners and then bring everyone to the table together such that there's never that awkwardness of like, well, I'm doing this and you're doing that. Instead, we should all be working towards one goal, which is to improve outcomes and help more children survive. And so that means that whenever we would start working in any partnership, we engage everyone, high income, low and middle income, NGOs, as well as government, etc. And then finally, this was fundamental to our approach from the outset. We would not subscribe to any neocolonial practices. Our goal was to convene and with those other four, really ensure that this was of mutual interest and mutual benefit. And so we started in 2017 really with a focus locally, recognizing that we were not going to build an entire community overnight. And we needed to develop both trust as well as demonstrate our commitment so that others in the region appropriately wouldn't just say, oh, well, St. Jude's coming in and now, like, whatever. We wanted to show that we were there for the long haul and that we had long-term relationships that we want to build. And, that ultimately means that we needed to develop relationships, personal time on the ground, and really spend time understanding what the local needs were through support of clinical care, not really investing in development of research programs as a first step. We spent a lot of time doing mentorship, a lot of time understanding local challenges, and then, like I said, co-designing what were the core needs from all partners on the ground. But then as a next step, we started to get more and more interest from partners throughout the region. And from that, we really started to think about how can we begin to convene nationally. And actually, not if one program in a country invites us, it doesn't mean that we work with only that one program. The first question is, okay, so who else in the country has services for childhood cancer? Let's bring them all to the table. And then let's bring their partners to the table. And then let's bring government, and then let's bring NGOs, and let's start to think about how we convene national solutions and priorities, not St. Jude priorities, and not just only the single hospital. And you'll hear more about this profile program in a bit, but we've done this process now in 18 countries, partnering with 73 institutions in the region, doing a variety of different tools from quality improvement activities all the way to national agenda setting, oftentimes led by governments. And this has been in collaboration with St. Jude, but really led in almost every country by ministries with us to facilitate, as well as either professional societies, NGOs, and or key clinical leads in each of those countries. And then most recently, we've been working to build regional efforts and programs. And that's really been about understanding from those national led efforts that out of those efforts, each of those communities have had 10 to 12 national strategies. It turns out of those 18 countries, almost all of the national strategies are overlapping. And so there's high levels of synergy that we've identified. And that means that we can, instead of having to have 18 different national programs, let's actually work regionally and have each of the programs self-identify their own priorities and then partner with other programs in the region to build and foster South-South collaboration. And then finally, we've now seen that growth start to pay dividends. So this just shows you from our quality improvement tools, our implementation science efforts, our research education efforts. In 2023, there were about 18 programs that we were engaged in across the region. But today, now, as of 2025, and of course now it's even more, we've had 55 different programs. So we've seen a massive exponential growth of activities in the region across all of the hospitals and programs. And of course, this has been from the Global Initiative for Childhood Cancer, for those that are not aware, that is the WHO initiative for childhood cancer, much like that for breast cancer and cervical cancer, except this is the WHO with St. Jude being the primary implementation partner, both as the one and only collaborating center for childhood cancer. There's been over 15 countries engaged, and you can see that there's high overlap with those profile countries for their engagement in the GICC. We also have our Global Alliance, and that Global Alliance really is our partner organization. So we have structured MOUs with 45 institutions, 17 currently in progress. But that Global Alliance also brings in foundation members. So we have nearly 20 foundation members. Again, these are MOUs between St. Jude and each of these institutions or foundations, which also then allows us to then engage in research or program of quality improvement efforts. And so this effort and data sharing and all of these things. So this is constantly growing and been a part of our global strategy for growth as an institution. And then last, just to note that this is not being done as St. Jude in the region. We've actually developed as a global alliance. Like I said, we have over 400 hospitals now in our St. Jude Global Alliance from 90 countries. You saw there our footprint in Sub-Saharan Africa. But each region has its own regional committee. I show here a Sub-Saharan African regional committee as well as the key members on that. I serve as the chair. Geeta Naidu is kind of the secretariat as the hub director. And then we have 7 regional key leads from institutions from around the region that represent the totality of that region as well. And then we also have one for the EMROS as well. And so there's a Moroccan lead on our Eastern Mediterranean, because our model mimics that of the WHO regional programs as well. And so with that kind of tells you a little bit about who we are and how we've grown now over the last 7 or 8 years. I'm going to now hand it over to Geeta Naidu, who will be able to share more about our regional hub and then take you through an example of some of the programs that we've been doing in the region to support activities and improve outcomes. Aya, over to you.
Good evening, everyone. Can you hear me?
Yes, we hear you.
Yes, we can.
Aya, you
Thank you.
share slides.
So I'm Geeta Naidu, and I'm based in Johannesburg, South Africa. And I've recently taken over as Director for Pediatric Oncology for Sub-Saharan Africa region at St. Jude Global. Next slide, please. So a little bit about the regional hubs and what we plan to do with them. So in 2018, St. Jude Children's Research Hospital developed their department of St. Jude Global. But I think the history is a little bit longer than that. The Bakta family is actually from Zimbabwe and from Zambia. So even though we had a long engagement with St. Jude Global, I think this predates 2018. So the first regional hub was established in Dubai for the Eastern Mediterranean region in March 2025, and then in Johannesburg in November 2025. And the next one will happen in Mexico, hopefully by 2027. But there are other regions that will also be included. Next slide, please. So, what do we want to do with these regional hubs? And there's really four key functions. I'm not going to go through all of this that's written on the slide. The first one is network development, to develop and maintain relationships with key partners on the continent. The next one is capacity building and patient-centered care. That is really to develop and strengthen health systems and patient-centered initiatives. The third function is about education. How do we support to train the local clinical workforce? And the fourth one is for research, to advance knowledge in global pediatric oncology and hematology, and how do we share that with the rest of the world? Next slide, please. Sorry, just a little more about the regional hubs. We really want to empower collaboration on a global scale. And the hubs will really function as extensions of what we call the St. Jude headquarters. And to strengthen partnerships with alliance members, Dr. Nikhil Bhatta spoke about the global alliance members and how their numbers are increasing, and to serve as regional and local connection points, to also provide strategic thinking and visioning, and to bolster learning. And so to me, these are the most important functions that the hub will really want to carry out in the different regions across the globe. Next slide, please. So Dr. Bhatta spoke about the various transversal programs that exist at St. Jude's that have been now employed in many regions of the world, including Alliance hospitals, Global Alliance members, and also those who are not. So the one, and these transversal programs, really, there are so many. It's the Metrics and Performance Unit. Dr. Bhatta mentioned Profile. It's also in the areas of critical care, palliative care, infectious diseases, global hematology, the SJK's registry, the tumor boards that we have every Friday, the resource adopted management guidelines, the GICC, and also the global platform for access to childhood cancer medicines and radiation oncology. So the example I want to talk a little bit about is that from the infectious diseases department. So as you can see here, Dr. Sheena Mukada, she is from the Infectious Diseases Department at St. Jude Global. She and her team, together with the University of South Florida, have been working on regional guidelines. So one of the ones that Sub-Saharan Africa and South Africa was involved with was the febrile neutropenia guidelines. And as you can see, we had two panels here, South Africa and Sub-Saharan Africa. But there were other regions as well. And together with the St. Jude's Global Analytics team, the Washington University Implementation Science team, and the St. Jude Global Research Core team, we developed febrile neutropenia guidelines for our region. Next slide, please. So this was the Sub-Saharan African panel, and as you can see, there were many countries, and some of the countries, for example, Ethiopia, had more than one hospital. Next slide, please. And this was the South African group, and I was part of this group, and we had 9 institutions involved in the guideline development. We had an array of people from pediatric oncologists, microbiologists, pediatric infectious diseases specialties, and also parent representatives. Next slide, please. So the guideline development, just briefly to go over how we worked on this. It was quite an intensive program that each member participated in. We had weekly meetings. So firstly, we drew up this guideline panel. Then we had the prioritization survey. Which topics should we include? Then we finalized the guideline topics and we did the grade training. We then went on to the literature review and evidence synthesis. And then we developed the guideline and we wrote the guideline manuscripts. So you can see at the bottom here, the Sub-Saharan Africa region manuscript has been published in JCO Global Oncology, and our South African one is in the press. Next slide, please. So the next step in this process was, now that we have the guideline, how do we use this guideline? How do we improve the care that we are offering to our patients? So we had a series of workshops looking at what is the core package of this implementation strategy? And also we looked at what were the site-specific implementations. So this was, I'm not going to go through all of this, but it was quite a detailed exercise that the people who wrote the guidelines, together with the St. Jude team and the University of South Florida team. So this was, to me, it was really important that we went through this in such detail, because there's no point in having the guideline. The most important thing is, how do we implement this guideline? Next slide, please. So when we looked at this guideline, there were different projects that came out from it. The one is, as you can see on the left-hand side of the screen, the nurse-initiated antibiotic timeout, which is an important project. And equally important is the fever registry, which is the global fever registry. So there were 8 sites in our regions in Sub-Saharan Africa, which will participate in data collection to inform local care, regional best practices, and research through this activation of the fever reg. So this is something that the teams are now preparing for, being educated about, participating in training for this part of the guideline implementation. Next slide, please. So one of the ways in which this guideline will be implemented is there's this improvement science in action, which is led by the Institute of Healthcare Improvement and St. Jude's. And it is the early fever management package. And there are various sites across the globe that are participating in it. There are 4 regions, 24 hospitals in the LATAM countries, 13, and in Sub-Saharan Africa, 10 countries and 1 in the Euro region. So this is a 6 to 8 month project-based curriculum. And it really is to empower healthcare workers on evidence-based quality improvement methods on how to really deal with real-world problems. So to me, this is a really important part about this guideline, that it was developed. Now there's this course on how it will be, how to implement it, and how the data will be collected. Next slide, please. So when we look at childhood cancer, we know that this requires complex health interventions. So many people will use what they call a treatment plan. And coming from my hospital in Johannesburg in South Africa, my hospital was one of those. We had the basic drugs. We didn't even have the proper guideline. We had some pieces of paper, and this is what we used. When we talk about the guideline, we know that this is what is contextually appropriate. It's comprehensive, a comprehensive management plan, but until now, we haven't had that. But now, with the work that is being done by St. Jude's and partners across the world. This is what I will talk about next. When we talk about protocol, I think a lot of us mistake a protocol and we think about that as a treatment plan. But as Nikhil Bhakta very well explains this is a research quality improvement project. And for most of us in low and middle income countries, it's really out of our reach to be able to do the work, to have the resources to write up these protocols. So that leads me to the next part of the work from St. Jude's. Next slide, please. Sorry, next slide, please. So now I want to talk a little bit about the ARIA program. So this is a St. Jude SIOP Childhood Cancer Guideline initiative, and it is to facilitate global therapeutic decision making. And for me, the most important part about this guideline development, and I've been involved in one of them, is that we have representatives from all regions of the world. And when I first started with this, I wondered, what am I going to contribute to this? I'm not from a high income country. I've never been involved in a guideline development. And there again, the words of Nikhil Bhakta echo is that, yes, we may have the content experts, but for people like me who reside in low and middle income countries, we may be the experts of our context. And I think that's what is really so important for me about the ARIA program. And I really believe it is going to change how we treat children across the globe. And it's really about adaptive management guidelines. We've had people from all over the globe, from high-income countries, low-income countries, upper middle-income countries like my own, who've been part of developing these guidelines. Next slide, please. So this is really an accessible dissemination tool, and it is called the ARIA Guide. Next slide, please. So it's really about it's been a worldwide global initiative, including regions, countries, and hospitals. And it's how we've taken standardized guidelines and developed them. And because each little region, each little country in the world, we do not have the time, we do not have the capacity, we do not have the human resources to work on these. So to have had a project that was initiated and led by St. Jude's, where we've adopted and adapted guidelines to create the ARIA guideline. And to me, the next part of this will really be to implement the guideline. And it is available on aria.org for anyone who is interested to see those that are the guidelines that are already available. Next slide, please. So just to talk a little bit about the ARIA Guide, it's about diseases, supportive care, palliative care, survivorship, and there are 120 planned living guidelines and clinical recommendations. There are 58 guidelines in progress. 25 are freely available, and they're freely available. Anyone can access them. 693 global reviewers have been engaged and 90 countries have been represented. So as I said, I truly believe that the ARIA guideline is going to change how we treat children with cancer around the world. Next slide, please. Yeah, and I think really I want to thank St. Jude for all that they have done to reach out to countries like my own, hospitals like my own, not only on the sub-Saharan African area, but around the globe. And I think history will judge them very kindly. And this is a quote by Nelson Mandela. Thank you very much.
Thank you, Prof. Naidu.
Thank you, Prof. Naidu, and thank you, Ayo, for bringing up my slides.
I am Glenn Ba. I am a nurse. I live in Bamenda, Cameroon, where I teach nursing and pediatrics at the University of Bamenda. And I also provide program support to the St. Jude Sub-Saharan Africa team. My research work is focused around system strengthening and capacity building, nursing capacity building for better access to care for children with cancer. So today I'm going to talk about some practical tools for systems strengthening. And particularly, I will talk about the SJKS registry and the profile tool. These are really complementary tools developed by St. Jude Global that help to support system strengthening for childhood cancer. And we've seen it used with very impressive and very useful results for low and middle income countries. Next slide, please. So why do we need these system strengthening tools? We all know that childhood cancer survival gaps. We know of this 80% survival in high income countries and around 20 to 30% survival in low and middle income countries. And it leaves this huge gap that we all have to do our part to fill. But most of the survival gaps are not due to the biology of the cancer itself. It's not due to the treatment, because for many of those diseases, the same treatment can be available in low and middle income countries. However, it is around the systems. We see that the systems in low and middle income countries are usually weak, and the countries often collect or conduct assessments through, but they struggle to translate the assessments that they conduct into coordinated or measurable action. Next, please. When you look at the Global Initiative for Childhood Cancer, which Nikhil mentioned earlier, the aim is for 60% survival of children with cancer across the world by 2030. And the GICC Global Initiative has elaborated this toolkit, this guide, and it has 5 pillars. One of which is the pillar of evaluation and monitoring with quality assurance and information systems. So you see, this is very critical in coming together to improve survival rates. So we need systems that we can monitor. But one key policy enabler for this is policies and linked governance. So we also need a method on how we can measure, but use the measurement, linked them to policies that can improve services and improve outcomes. Next slide, please. So the first tool I'm going to talk about is basically for cancer registration. And I'm going to do this reminder of what cancer registration is. It is a process of continuing and systematically gathering information about cancer occurrence in a community so that it can inform about the risk factors, the management, the capacity, the outcomes of cancer in the country. So this is very useful information for every country, for every health jurisdiction. And what the International Agency for Research in Cancer strongly advocates for is population-based cancer registries, because those are very useful. They can tell us information about risk factors especially. And when it comes to adult cancers, that's very critical because we want to prevent as much as possible so that we don't spend so much treating. When it comes to childhood cancer, however, there is this other side of cancer registration which becomes a bit more critical because it's hospital-based registries. And because we cannot prevent childhood cancer, we focus a lot on early detection and management so that we can improve survival. And what hospital-based registries help us to get is information about diagnosis, about delays, but also about the treatment and the treatment outcomes, which will talk about survival, toxicities, and things like abandonment, which is in low and middle income settings is very important. It gives you an overall the quality of the care that you give, and a measure of the survivorship and the success of the program that you have for treating children's cancer at the facility. Next slide, please. So we've seen many authors and many colleagues from around the continent present their data on cancer, pediatric cancer at facility level, hospital-based data. But time and time again, you see the same challenges coming up. There are so many different systems. And with so many different systems, it becomes difficult to combine and compare data across settings or across countries. There's lack of training. So people develop their tools and they use them by their own intuition. There's few checks for data quality, and very often the data completeness is very lacking. And of course, there is the cost and the risks of managing heavy savers with patient health information stored in them. And it's not only about the cost, but also the legal implications for that and ethical implications. Next slide. And this is where the SJCares registry really comes in. SJCares stands for the St. Jude Global Childhood Cancer Analytics Resource and Epidemiology Surveillance System. And it's part of an integrated solution to support evidence-based pediatric cancer care decision-making in low and middle income countries. This is a tool developed by St. Jude Global. And with this, we'll see 90% of the variables are standardized for all the sites that are using this tool. So it solves that problem of comparing data to see how you are performing against another facility, against another country of similar income setting. The core variables are optimized for pediatrics and young adult, adolescent and young adult cancers. So the classification and the staging of the nomenclature of the disease follows a different model, which is specific for children, adolescents, and young adults. It's in multiple languages, and there is a whole team behind it, the St. Jude Metrics team, which supports you with training. It supports you with day-to-day troubleshooting. It supports you with data checking for quality control, and it supports with data analysis. So at the end of the day, it's really down to the facility's commitment to collect and input quality data with all these resources available to support the facilities. So it has a practical design. You know, you're collecting data longitudinally from the time the patient presents at the facility to diagnosis, to treatment, to post-treatment follow-up, to survivorship or bereavement. So, and you have patients that you enroll at different time points. But this system helps to give you prompts at each time point so that you go in and you enter the data. And when training is provided for the use of this tool, is provided for 2 persons at each facility at least. There is the data entry specialist, and then there is the MD monitor. So the monitor checks the data that has been inputted by the data entry specialist, so that it already at the facility level, there is that check for quality. And then at the level of the St. Jude's metrics team, there is a second check for quality. So it really has that advantages of quality control. It has the cross-site benchmarking because the indicators are similar across different sites. But when it comes to a registry, it can give you all this information about your outcomes, your treatment, how well you're doing, how well your patients are doing, even things about abandonment of treatment, it can tell you. But it does not explain why you have gaps in your system. It will tell you you have abandonment. It doesn't explain why you have abandonment. And it does not prioritize which interventions you should implement first in order to make the best benefit for the effort. So that's where the next tool comes in. Next slide, please. So next, please. This is just a schematic of the timeline for entering data. And like I said, there's prompts at each time point for data entry. And then it brings us to the next tool, which is the profile tool. Profile stands for Pediatric Oncology Facility Integrated Local Evaluation. And this is really a dynamic tool that allows you a 360 service delivery evaluation for childhood cancer centers. And this is an assessment which an institution can undertake collaboratively with support from the St. Jude Global team, but very much intuitive with guiding manuals on how to take the process step by step. It's not an audit, so it's not meant to make people feel bad about themselves, about their performance, but it's meant to give you a baseline, gives you a 360 view of how well you're doing, where the gaps are. It has 5 main components. It tells you about the context, and these 5 main components are again divided into 12 modules. So for the context, for example, you look at the national context, you look at the facility context, and you look at financing. Then you have workforce, which talks of personnel, it talks about service integration. You have diagnosis, you have therapy, all from chemotherapy, surgery, and radiotherapy. And then it gives the final, or the fifth component looks at your patients and their outcomes. So how they come in and how they go out. Next slide, please. So again, this tool is it's very practical, and there is a whole team behind it to provide support. So it's very structured. It has 3 key phases. The first phase is where you engage your stakeholders for the facility, but also at the national level. And especially it's important to get Ministry of Health leadership when such an evaluation is conducted across multiple sites in the country. And then the second part is where you actually undertake the assessment. And there is a whole questionnaire which helps item by item to evaluate different aspects of the care delivery at each center. After that is done, that data is analyzed by the St. Jude metrics team and is provided in graphics, in text, in figures, and the facility can have time to look at it. And one thing which it does is it gives you the objective performance, but it compares it against your subjective assessment of how well you thought you were doing. So it really helps you to measure your self-judgment against the objective measurement. So once if you use that data, you've looked at how well you're performing, the next phase is to get into a national stakeholder workshop where various sites in the country that have undertaken this assessment will come together through a series of structured exercises, identify key gaps, use this gap to make recommendations, go on to prioritize the recommendations using an impact effort matrix so that they get the best, they can choose the most pressing priorities to address. And once that is done, it ends up in an action plan. An action plan which has input of all the different stakeholders in clinical care, in advocacy, in family support, in policy, and this becomes a plan that can really be practically implemented at the national scale to improve services at all the centers in the country. Next, please. So the key mechanism here is the stakeholder engagement. The stakeholder engagement is very critical, and as Nikki said earlier, these processes are co-designed. So you do the assessment, yes, you send the data to the metrics team, they give you back the analysis, But again, you go back to the workshop, you review, you agree or disagree with priorities identified, and then you pick out what you see and find a consensus of what you believe are the pressing priorities, which when addressed will have maximum benefits in terms of patient care delivery. So, and you end up with smart objectives and timelines for implementing them. Next slide. So I'm going to share some examples from countries across sub-Saharan Africa. I'll start with Kenya, where when the profile tool was used in Kenya in 2021, I think, in 2021, it brought different stakeholders from different hospitals and different parts of the Ministry of Health, and they came together and agreed on common priorities. And beyond that, groups have been set, working groups have been created, and there's even a technical working group that coordinates the activity of all the different priority action groups. So this has really moved things forward in a national approach, as opposed to individual facilities making improvements in their own corner. The next country is in South Africa, where again, the profile tool was applied. And in South Africa, it brought all the, the tertiary, different hospitals where pediatric oncology care is delivered, and they agreed again on common priorities, as opposed to fragmented facility perspectives. They came together and had national priorities like registry, to strengthen cancer registries, to standardize multidisciplinary team discussions, and address issues like chemotherapy safety. And again, working groups have been set for each of these priority actions, and they've been working continuously on those priorities over time. And in Cameroon, we use the profile tool and assess our facilities for pediatric oncology, engage the Ministry of Health, which really led this evaluation and this priority setting with an action plan that was developed and has been used at multiple levels, at advocacy, at the facility level with other stakeholders, including NGOs that provide support for services. But one very important thing which came out of our prioritization exercises, we tried to align it with the National Cancer Control Strategy, and it ended up entering or becoming a tool for the Ministry of Health, which they used to approach the WHO and became admitted as members as focus country of the Global Initiative for Childhood Cancer. And that has really guided. We have gone back 2 years later to reprioritize on those priorities and continue, taking bite sizes and addressing the most pressing problems with the resources that we have. And one thing I want to say is, all along this process, the St. Jude Global team is available for support. The St. Jude Global doesn't only have the tools, but they also work streams, research groups, and research projects that all continue or contribute to strengthening services at facility and at national level. Thank you very much. So yeah, so I'll just to conclude by saying these two tools I've mentioned, the SGCS registry and the profile tool, are really strong tools in their own merit. But when you use them in an integrated manner, you see that it gives you the tool that you can use to evaluate services at the facility as a registry, which can fit into national registries or population-based registries when the time comes, which you can use to compare performance between centers and between countries. But it also tells you you to identify why the gaps exist and what can be done about the gaps so that you can prioritize and act. So thank you very much.
Thanks so much, Glenn.
Joyce, over to you.
Yes, thank you. Good evening, everyone. My name is Joyce. I'm from Uganda, and I have the honor of moderating this Q&A. We have just about 6 minutes. And so if anybody has a question that they would like to ask about, I wanted to prioritize you rather than asking questions that we had in the first place. So I see a hand up from Christopher. If you could unmute yourself and ask your question.
Okay, thank you very much. I'm Christopher Williams. I'm talking from Canada. It's been a pleasure listening to you guys, especially with the guys from St. Jude's. I just have a few comments. First of all, and I've asked this question before in some of our earlier presentations, what exactly is global oncology? And why does it always have to do with low-income and middle-income countries? Yeah, not with Australia, not with Japan, China, or Europe. It's always Africa. So is Africa the global place, the only place for global oncology or not? And that is a little bit confusing for me. Now, it's been interesting to listen to the various speakers, Dr. Bacter saying that St. Jude's program is not a form of neocolonialism, and I agree with you. St. Jude's programs is a presentation of St. Jude's vision of the world. But that doesn't have to be the vision of Africa. Now, I have to remind you that the first curable childhood cancer in the world was discovered in Africa, Burkitt's lymphoma. The first curative treatment for childhood cancer was developed in Africa. Cyclophosphamide for the treatment of Burkitt's lymphoma. And that is what led to the development of treatment programs for the treatment of cancers in the developed countries. Acute lymphoblastic leukemia was not curable in the 60s or the 70s when the treatment program started, with the so-called, various cooperative programs. That it has now led to care of acute lymphoblastic leukemia and Hodgkin's disease. All that started in Africa. And now the whole thing is now going backwards. So now this should be an eye-opener for you Africans who are listening on this program. You keep your eyes open. You need money. There's a lot of money in Africa. St. Jude's is doing what they're doing because they've taken American money to develop a program that is spreading all over. Now we're talking about the area guidelines, and that is why AORTIC was created, to train Africans to manage their cancer programs. Anyway, I don't want to take too much time. Keep your eyes open, you Africans. And I thank St. Jude's for your presentations. Thank you.
Thank you, Professor Chris Williams. For our St. Jude visitors, that is one of the founders of AORTIC. So I would have loved your camera to be on so that they can see that this is one of the reasons why we have AORTIC formed and still standing.
So that's me, that's Chris Williams. Thank you.
All right. So I hope you're keeping warm, sir, in Canada.
I'm trying to. Thank you.
All right. So again, as we're waiting for questions and comments on this, I will just quickly, I'm going to rattle some of my questions. Pardon me, I'm not a pediatrician. I want to use this opportunity to say hello to my colleague on the clinical trial leadership platform, Lena. Hi, I'm calling you out. So it's nice to see you here on our team. Hi, Lena. We are both colleagues on the ASCO clinical trial leadership team. All right. So a question that I do have is, I just wonder how, I mean, I'm not a pediatrician. I just wonder how institutions or pediatricians or ped oncologists on the African continent who are part of this discussion, if they want to be part of your team, who do they reach out to, and how do they actually get involved in this good work? And so, and then the other question I have is that, guidelines is not very easy to develop, but I think is the easiest of it all. The question is always, how do you implement? What do you put in place to make sure that these guidelines, there's uptake of these guidelines, and how do you measure it? It's a lot of questions, and I just wonder, I'm a breast oncologist, and for example, something as easy as molecular subtyping for breast cancer diagnosis that has been introduced into the continent over 25 years ago still have less than 50% implementation. So the question is, when you develop guidelines like this, do you have things in place to make sure that this is there's an uptake of these guidelines, and to measure in time how this is being implemented in institution or on the African continent, and to make sure that, okay, do you have a timeline? Because I know this was developed in 2025. Do you have a timeline with which you want to see reasonable uptake, up to 100% uptake if possible? And then the other thing I have is just a comment, which is, we know that culture always eats strategy for lunch. It's the same, whereby you have to start thinking about the culture of an institution, an environment, when you're bringing in initiatives like the SJ Cares, the St. Jude profile, and what have you. Given the low resource setting, meaning the low human resources that has plagued our system, how do you hope that these tools are effectively used? And then, when in the case of St. Jude profile, when you do identify something that needs to be fixed, again, given the brain drain that we have in that in our environment, how do we get human resources to be able to actually implement all those things? I hope I didn't rattle. Thank you.
Thank you very much for all the questions. Glenn, just a second. Because you seem to be hijacking my microphone, but that's fine. I wanted to, first of all, acknowledge Christopher's very thought-provoking comments. I'm not sure that there are very specific answers to them because they're very philosophical, but it is something that we still continue to think about. And we shall continue to think about it. Professor, you made some very important points there, and I thank you for them. I would like to invite Gita to respond to the question on febrile neutropenia guidelines, and then Glenn, you can respond to the second question. I think there were numerous questions that were directed to you, and then after that we can take the next comment from Teresa.
Hi, Joyce, thank you very much. So talking about the febrile neutropenia guidelines, yes, firstly, we have to ask ourselves if there are existing guidelines, be there the ITSA, the North American or the German or the British or many other countries have them. What is the need for us then to go on to create new guidelines? And these are conversations we had with the St. Jude team, with our African counterparts, and the guideline development team, the methodology team at South Florida. And really, those guidelines, the existing ones from high-income countries, don't really address all the issues that we face in low and middle income countries. For example, our guidelines have notes on tuberculosis, on children living with HIV, with malnutrition. So I think this is the reason we went ahead to create guidelines that were more specific and that we could relate to. So for me, that was the reason we went on to develop the guidelines, but it was a very, very complex process. It was not something that we as a South African team or a Sub-Saharan African team could have done on our own without the support of Sheena Mokada's team and Ambuj Kumar's team. So this is just an honest reply from me. Yes, we know that we need the guidelines, but we do not have the resources, the tools that it took to develop these guidelines. Thank you. I hope that answers your question.
Yes, it does. I'm waiting for anybody that has any questions. All right. So in the absence of any questions or comments, I really want to thank the St. Jude's team. 1 hour is never enough for these conversations, and this is exactly what we've always been discussing, and this is the reason why we created this North American series. That is to be able to show collaborations, to show more information amongst the practices and institutions and continents. So as we are ending this conversation and this session, again, with a big thank you to St. Jude's, to also our members that attended, we have to quickly highlight the next team for March and April. That is going to be the Mass Gen team, which we're going to be presenting next month. And also tomorrow is World Cancer Day. And I believe that AORTIC, we have a conference that we're going to be giving a talk about that. Our president is going to be giving a talk. We're going to be sharing the link to all the attendees today and also in our website. Again, like I started discussing early this hour, we have Best of ASCO Africa coming in Abuja, Nigeria. Please save the date. It's July 10th and 11th, 2026. And again, the theme, we continue to discuss access to innovative technologies, therapies, and resources within the continent. And we hope that St. Jude's will be able to, our SIOP team members will be able to be a part of this discussion. When we had this conference in Ethiopia of 2025, and we did a survey where we asked questions to our attendees, one of the things they said to us and they dinged us on was that childhood cancers was missing. So, and they gave me that feedback. I'm not yet sure how we're going to plug that into it, but I think this is a timely conversation and discussion, and we hope that you can actually help us and support us in this conference and actually add the childhood cancer piece that is missing. All right, so as we are rounding up this, is there any questions or any comments from anybody on the team?
Abiola, if there are opportunities to engage and include childhood cancers, please, myself, Geeta, Joyce, Glenn, we're all available to you and can always pull stuff in. So don't worry, we have more than enough to engage.
Right. So now that we're on that discussion, I have a very good friend of mine, Dr. Adedayo Joseph. She's on this meeting right now, and she's so involved in childhood cancers. And the two of us, actually, we are on the clinical trial special interest group together. And also she's actually part of the planning committee on this. So I think she's going to be the connect or the liaison with your team. And yeah, I know you work, of course you work with Dr. Joseph. She's a powerhouse.
She'll be in Memphis soon, hopefully.
So right. So she's going to be the liaison, and we're going to get you involved with that. So again, thank you so much for this. This was very powerful. This is, as usual, every time I come here, every first Tuesdays, it's always a learning session for me. And I hope everyone was able to take away a lot of information like I did. All right. Thank you till we meet again next month. It is incredible work. Thank you. Thank you for now. Bye-bye.